Them?
Yes, please.
Hi, everybody. My name is Tanaz Boyle. I'm a pediatric emergency physician and a health services researcher at Boston Medical Center. And it's really exciting and in my honor to be moderating this webinar today. I like that my name is up there, although I am just moderating. I am not presenting. But anyway, so this event is hosted by the Region 1 Disaster Health Response System, where I am the telehealth lead, as well as our partners at the Pediatric Pandemic Network and Region 5 for Kids, who have really been incredible partners and champions of disaster telemedicine. I'd like to thank Damien and Jack Lieber, who are both project managers extraordinaire, who have herded cats for a long time and have responsible singularly for making today a reality. This webinar was really inspired by our Cross-Sites Telehealth Working Group. This is a multidisciplinary group that came together now several years ago at the inception of or early in our program development, and represents telehealth team members from each of the 4 current regional disaster health response systems, or DHRSs, the Pediatric Disaster Centers of Excellence, and then new additions with the Pediatric Pandemic Network, as well as our colleagues from the ASPR Disaster Telemedicine Program. Our mission in this working group is to really foster collaboration, and the goal is to work across regions so that we can develop and implement and really enhance regional telehealth systems to fill the gaps in disaster response within the United States. Our goal is to be really collaborative, to innovate and to share knowledge. And so with that in mind, I'd like to introduce today's speaker and her team, Commander Passman. Commander Passman is the director of ASPR's Disaster Telemedicine Program. I first met her in 2021 when she joined ASPR as the program manager for the National Emergency Telemedicine Network. She has served in a variety of different agencies, including HRSA, SAMHSA, HRQ, such an alphabet soup, in various roles, and she is incredibly qualified. She has a master's in epidemiology from George Washington University, a graduate certificate in public health informatics from Hopkins, a certificate in global health from the Uniformed Services University of Health Sciences, and most recently is a PhD in urban sustainability at the University of the District of Columbia. So welcome, Commander Passman, and we look forward to hearing what you have to tell us about the ASPR's new disaster telemedicine program.
Thanks, Dr. Boyle, and thanks everyone who's joined and our Region 5 colleagues. I first want to make sure that my team is here. So Dr. Crabtree, you're on?
Yes.
Great.
Hi, everybody.
And I don't know if Amy's on yet, but she will be. Okay. Well, why don't we just launch into it? I know you guys have a lot of good questions probably for us. So without further ado, I'm going to present about our ASPR Disaster Telemedicine Program with our team members, Chris Crabtree and Amy Keim. We, just so you know, do not use the NETN terminology now, or the National Emergency Telemedicine Network, because it did not really fit our activities. So we don't have anything snappy yet, but we'll just call ourselves the Disaster Telemedicine Program at this point. So hold on a second. Okay. Can everyone see mission and vision?
We cannot see your slides.
Can?
No.
Oopsie.
Not being shared.
Oh boy. Yeah. I'm the one who does this. Okay, hold on. Sorry about that. Forgot that step.
We can see them now.
Okay, so just to go back, this is our title slide. These are our team members, and you will meet them other than Commander Tung, who is at a Department of State training right now. So I'm gonna go over a few things with you today. I have a program overview. So you have sort of the basic details at a 10,000 foot level. We're going to talk about the specifics of our telemedicine capability, get into some of the technical descriptions. And then Amy's going to present in depth about a use case and how we see this, an operation unfolding in that use case, including clinical workflow and other things that I know you'll be much interested in, as well as our reporting. As you probably know, you have to do something that we call in the business feed the beast, and we also need reporting for our own purposes to make sure that we're doing what we should be doing and that we catch any issues that may arise during the provision of remote telemedicine service. And then I'll talk just a little bit about that, and then we're going to open up the floor to all of your questions. Pardon my, I'm just transitioning from a lot of meetings today. So, all right, so we are in the process of honing our mission and vision statements, but just for now, I think it'll help you to get an idea about what we're about here. So the ASPR Disaster Telemedicine Program's mission is to provide the best care to disaster-stricken communities while using remote clinical specialists when and where they're needed. So that's our overarching objective here. And in terms of our vision, we will provide unrivaled virtual specialty support to federal emergency responders and their partners. So I hope this gives you a good idea of where we're coming from before we dive into the details. From the high level, we have a few different priorities for the coming months. The first one is to achieve what we call initial operating capability, or IOC, for our platform and capabilities so that we can start to deploy it in scenarios where it's appropriate, as well as exercise it and strain the system so that that will inform our development further on. So we have some telemedicine exercises coming up, one with a foreign partner, another inside the federal government that relates to patient movement. So we're involved in a lot of stuff, and we will incorporate telemedicine into all further exercises that are being done at ASPR. So finally, at the beginning of next year, we hope to have full operating capability, or FOC, so that we can leverage all of the capabilities that Chris is going to describe to you and be out there as the federal telemedicine, disaster telemedicine capability. Chris, do you want to start with the architecture?
Yeah. Can everybody hear me okay? Okay. All right. So the disaster telemedicine, our disaster telemedicine capability or architecture first is just the contract is, it's an full service soup to nuts contract that includes not only the telemedicine piece, the digital platform piece, but also includes equipment, includes the servicing and rehab and maintenance of that equipment, as well as the clinical specialty staffing. And I'll get into a little bit more of the details of the capability if we can go to next slide. Thank you. So it is as you know, cloud-based system. I mentioned the synchronous, asynchronous aspects of it. But one thing that what we're excited about is the utilization of the digital technologies and services that are provided through that digital technology as not only a functional integrated part of our disaster telemedicine system, but can be individually leveraged as a standalone capability to fill gaps that we've recognized that have existed, and they've had a hard time trying to fill those. And those are something like EMR is one, just a robust capability. The eScripts is another. Currently, that capability doesn't exist within NDMS. And so we're helping to provide for that, in addition to that capability for whether it's shelters, whether it's clinics, or providing additional services on a deployment using that. Also, the health information exchange service and the EMR system patient lookups. Again, another capability within the system, but can be leveraged solely for that. For example, is if our NDMS DMatters wanted to just look up some patients and they're utilizing their EMR, they can just use our system for that. The same way for eScripts. And then we have interpretation services, which is a big deal. 250 plus languages, and they have the ability to just utilize that if they want to use audio or video and for a language, or if they want to use it as part of an integrated part of a televisit, they can as well. API integration, you may be familiar with that. That's just that ability that allows us to talk to biomedical equipment as well as other systems and for more interoperability. The phone-only option, we wanted to make sure that was part of it as well for those that may not have a computer, may not have a smartphone, that affords them the opportunity to utilize the system without advanced technologies. And obviously connectivity. We wanted to ensure that there was a fail-safe connectivity system where you have cellular and satellite kind of nestled into a cradle, where if cellular service was less than 50% optimal, that it would automatically kick over to satellite, and to afford that redundancy. Equipment, I mentioned about the storage and rehab, and we can go to next slide, please. Perfect, and the specialty staffing. Right now, we listed on our contract 28 specialties, and that was just based off of our conversations with NDMS and some of our other partners to find out, which specialists, if they had an opportunity, who would they, or rather, what type of specialist would they need or want to reach out to. And a big component that we added as a big part of our mission is behavioral health. So we added clinical social workers and clinical psychologists as well to increase that capability, along with obviously our psychologists that's on the list as well, to help with those missions. And we're in the process of building out our platform, requirements, work streams, in meetings. We hope to have that wrapped up, and obviously our security piece. And next slide, please. Okay, and let's see, let's get them. I think this is Amy's part, right?
Mm.
Okay. All right, and I will hand the ball over to Amy.
Well, I mess up animation all the time, so let me.
That was my punchline. All right. I want to spend some time talking about the clinical capabilities for our programs. A lot of, I think most telemedicine programs are very focused on the services that are going to be required by a specific group of people in a specific type of situation. And of course, we're all talking about disaster response here. And I think if I can get control of the screen. How do you get control of the screen? So we in our program have tried to really look at the different needs that present in different types of scenarios, with the first focus being that we want to, great, thank you. I think that's screen 2. I have control of screen 2, but not 1. Okay. Not moving forward.
Okay. Well,
Why don't you just go through them, Dina? I can just talk about them as we go point by point.
Okay, let me make sure that that's happening now. Okay, how's that?
We start with just the ability to increase the clinical capacity and close the staffing gaps that can occur when you have these situations where you have the surge and you need backfill. So we have federally contracted and credentialed remote staffing to do that, and we'll reach back to them via telemedicine. Next slide. Next. Yeah. Of course, we want to provide specialist consultation, especially those that are difficult to get access to in remote areas, including toxicologists, CBRNE specialists, burn specialists. Next. We want to enable medical oversight of providers deployed to alternative care sites. So these could be people who are working out in the field in shelters. So if you have an RN staffing a shelter, that he has access to medical oversight, can provide a higher level of care directly at that site via telemedicine. Next. And support task shifting to extend the capability of deployed workforce with just-in-time training. So this could be task shifting a EMT to provide a higher level of triage or treatment capabilities with oversight via telemedicine. Next. And enabling the guided management of critical medical devices by appropriate specialists. We know that from COVID-19 pandemic that respiratory therapy was a difficult skill set to get a hold of for facilities that didn't have those capabilities prior, as well as dialysis, and there are other types of specialists that we can pull in. Next. The telemedicine program that we are designing also has the ability to get EKGs to cardiologists for that level of read. Next. And enabling real-time ultrasound, not just reading, but guidance. So we have novice providers in the field who may not be comfortable doing point-of-care ultrasound. They can be guided by an ultrasound specialist with those reads at the same time. Next. And real-time remote guidance of critical procedures. These are not necessarily for the novice, but for maybe somebody who has not, and we'll talk about this in a minute, who has not performed that type of procedure recently, or it gets more complicated than one would expect. And then providing behavioral health support. This is very, very big for everybody's response, making sure that we have behavioral first aid. If so many people, a team that can provide evaluations, counseling, medical management on the ground that can surge with the type of response. Next. And the ability to support these multidiscipline local and virtual decision-making that can occur through teleconferencing, regardless of the environment that we are responding to. And next slide. So our basic setup is a tab or a tablet or a laptop and integrated camera. We build upon that, next slide, to go up to the ability to integrate device options, including performing vital signs. We have a close-up camera, digital stethoscope that enables remote auscultation and listening to cardiac sounds, EKG, so those can also be uploaded spontaneously into the telemedicine platform and read by a remote cardiologist. Again, ultrasound, and the ability to look at very close images as well as to back up and get an overall view of the patient for, say, procedures or physical exam. And then a big part of this is controlling the environment in terms of the sounds that interfere and being able to speak simultaneously without cutting the other people off and making sure that you get a full story, full communication without breakdown. Okay, so let's talk about one of the use cases. I always feel like this gives us an opportunity to see the ways in which telemedicine can be used, because sometimes it's a little abstract to people. So in this case, we have a large-scale earthquake with mass casualties. We have an EMT that's performing triage in the field, and they come across a patient with a traumatic leg injury. Next. Casualty cannot ambulate but is stable. And utilizing disaster triage, next, the EMT is going to tag the casualty as yellow and go on to the next casualty. Next slide. At this point, transport to our disaster medical response base of operations is limited, and they're focusing on immediate casualties. Next. The EMT is now in the setting of a prolonged field care. So they're going to round back on those patients that they initially triaged. So 2 hours later, they go to re-triage the casualty with the leg injury. The casualty's pain has increased and the leg is swollen and discolored, but the triage category is still yellow. Now, this is an EMT. They're not accustomed to doing secondary triage, so they are going to stick with the start triage protocols. However, they are starting to worry about this swelling in the leg. They know that they need to elevate. They check the pulses. They're weakening. They're not sure whether this person really is actually an immediate. So what she does is she sets up next her tablet and initiates a telemedicine consult with an ER nurse to assist with secondary triage. Next slide. The telemedicine ER nurse recognizes the early signs of compartment syndrome and that the casualty will likely need a fasciotomy to save the leg. So the EMT, based on that information, elevates the triage level to red and then contacts dispatch. So in collaboration with the dispatch with this additional information and recognizing the exact need, dispatch can go look for a receiving hospital, an ambulance that can transport that patient. But in this case, the transport is 2 hours from the base of operations, but 4 hours for a hospital. Now, the EMT is not sure what that means for the care of that patient. So using an enhanced telemedicine setup, the EMT is going to initiate a telemedicine orthopedic surgeon consult and add the base of operations DMAT ER physician to the video call. Next. Together as a team, they're going to determine that the casualty needs a fasciotomy as soon as possible and cannot wait that 4 hours for that hospital transport. They move the patient to the base of operations. The casualty arrives, and the telemedicine orthopedic surgeon and the DMAT physician evaluate that patient together, utilizing the connected devices, including ultrasound. They're able to Doppler the leg. They can get some close-up views, as well as monitoring the vital signs. An emergency fasciotomy is indicated, but the DMAT ER physician has only seen the procedure, but has never performed it. So the devices are set up to enable the telemedicine orthopedic surgeon to guide the DMAT ER physician through the procedure. And voila, the blood flow is restored and the patient is improving. However, the patient now has large open surgical wounds, and there's no DMAT staff at that time that have surgical wound management experience. So the DMAT RN is going to who's managing the patient is going to get a consult with a telemedicine surgical RN who walks him through the wound checks and dressing changes and helps along with evaluating the wound with the close-up camera until the patient is transferred to the hospital for definitive care. Thank you. So this is just one example of how we have multiple uses of telemedicine that can be applied even for the same patient across multiple environments and across multiple types of providers. So in developing our telemedicine system, we've identified these use cases through needs analysis, and we've worked with NDMS and other stakeholders looking at where we can fulfill or meet that gap or close that gap and meet their needs. Our initial focus for what we deploy is going to be reach back consults and behavioral health. And we're working with our vendor to design a system that expands our clinical capabilities that are anticipated to a wide scope of anticipated operational needs. The telemedicine platform is combined with an EMR. And this makes it a little bit different because the EMR that we're looking at is quite comprehensive. We will be integrating NDMS experience and expertise. So we're working with people who have field experience and expertise in designing a EMR that is specifically meets their needs. And we're customizing it to optimize efficiency, the workflow, and patient outcomes. We're working with the vendor to build out our initial operating capacity with video conferencing, and then we're working towards full operating capacity with full EMR capabilities. Next slide. So just to give you an idea of what that might look like, our access, and we've worked, fortunately, we've had RDHRS Region 1, we've been talking to them about some of their experiences and some of the things that they've thought about through their approach to telemedicine. And even though we're using them in different ways, that thought process about ease of access, lowering those barriers to use, and being able to provide services immediately play a really important role in everything that we're doing, of course. So similar to what they're doing, we have the provider log in, and then they choose their resource, either telemedicine, rapid actions, or their administrative, and they're going to go right to the administrative resources. In terms of the telemedicine resources, we have options of the specialists, like Chris had spoken about, as well as other capabilities in our interpreters. So they can go ahead and choose that immediately. They also have the option to go to rapid actions. This may be just accessing the tracking board or the provider landing page, but it may be going to doing a rapid note to working on a ATLS flow sheet with an algorithm, or PALS, or pediatric ATLS, as well as goes directly to those specific resources like ultrasound, EKG, prescriptions. And then we have a behavioral health workflow. These all come together in this integrated patient record and tracking board that tie into the telemedicine tracking board, so that everything can be accessed from one screen, or they can go immediately to those actions that they're seeking. Next. This just gives you an idea of what that telemedicine patient dashboard looks like as well. And the reason that we have these separated out is because when people are looking for specific information, we want them to be able to access a broad range of information on that patient tracking board. And when they have a telemedicine patient that is active, all they do is click on that, and it takes them right to where that they are in that telemedicine patient dashboard. And we are working through a lot of this workflow, but this is the initial design. Next. And I'll just talk to you through some of these EMR features next. Okay. So again, this is designed specifically for clinical needs that we find in disaster settings, but also in recovery settings. Next. Has an intuitive interface and role-specific landing pages and modifiable permissions. And what this means is when somebody logs in order to take away all that clutter, anybody that's worked with these really comprehensive EMRs know that there is a lot of noise there. There's a lot of functionality and information that distracts them, and they have to search through it for the operations that they want to perform. Our program actually has a landing page where the provider, according to their defined roles and the types of permissions that the administrators give them, can go directly to focus on their patients and see exactly where they're at and what needs to be done, what has been done, and they can track that much more with a much more focused approach. Next. These rapid actions, we feel it's very important for people just to open up and get to the actions that they need. You may not be able to put in all of that background information that you're going to want with registration, but if you can just get an identifier in, you can start to use the resources. Next. And as I mentioned, we'll have flow sheets to guide people through some of these critical approaches to rapid management. One of the things that we've encountered that's really, really interesting is when we deploy, we have different types, according to what team deploys, different types of point of care testing devices. And each one of those devices has their own cartridges, and not every cartridge has a full chemistry or a full hematology. So we're setting it up so that when somebody orders, it's according to the cartridges that are available. And then we'll have APIs that will pull back that lab work into that EMR. Next. The connectivity enables us to work with the NDMS equipment, as well as some of the common EMS devices that are out there, as well as some of the DoD devices. And one of the neat features is we are doing epidemiological tracking. We want to know if a group of patients show up with a very similar appearing rash or a certain set of symptoms. We are setting it so that if we see a certain number of these that wouldn't be expected in a normal population or in the disaster setting that we have seen in the past, that it sounds an alert so that we take a look at that information and see that if perhaps there's some type of exposure or infectious disease that would have otherwise gone overlooked for some time. Another really interesting feature of this will be the identification and linking of accompanying family members or caretakers. Now, these people do not have to be patients. We have a non-patient identifier so that we can track if somebody is in the room. So if we have a pediatric patient and the parent is there, or vice versa, or if we have families that are together with different names, we have ways to identify those really fast and really quickly so that we don't lose these important contacts that we may need to reference, we may need them to assist in providing care, we may need them for disposition, and so we're going to link them in through the EMR. And next. And another interesting ability that we'll have is the ability to track the PAR levels of not just the pharmaceuticals that we're using and prescribing, but also the consumables. It'll give us a lot better idea of what is actually being consumed for what type of patients in what type of setting during those responses. Next. Okay.
Thanks, Amy. I will take it from here. And then we'll open up the floor. So just quickly, as I mentioned earlier, we need to have dashboards and reporting so that we can accomplish quite a few goals. One is situational awareness. One is, part of that is this epidemiologic tracking. And then we have all different types of leadership across the board. So we have leadership at headquarters who need certain information at a high level in order to help them with their decision making. We have people who are in regional leadership positions who may need other information. We have the incident management teams or the IMT there at the ground level, and they need other information. We have the clinicians on both sides of the platform. We have, our team. So those are just a few of the different users that we know we need to create reports and create dashboards for them. So the idea is that we will have dashboards that are customizable by the users. So we will sort of choose the maximum number of widgets, and then the users can choose which ones they want or they don't want. These would be canned or pre-populated for each of these types of users and reporting. And this information helps us to pivot, to make decisions about shifting resources and improving the response. These reports will also be downloadable and exportable so that we can share them. One thing we run into a lot, and you probably do too, is that you have maybe 6 different systems that you need to be logged into at the same time. They each have their own usernames and passwords and 2-step authentication methods. So by having these reports that we also can send via email is critical to sharing that information. So Commander Tung leads our effort for the data and reporting. So she's been exploring some different concepts in dashboarding, from the very simple thing of where do you put different metrics, what do the colors look like, how do you display them, are they bar graphs, are they pie charts, and then the actual data points, what do we need to know, and then and is it the most important information, or is it something, a secondary piece of information? So in this dashboard, you can see patient count in the top left corner. That's really important when we're deploying. And in our case, at the initial stages, this would be the patient count of anybody who had an encounter through the telemedicine program. And we would have, the rate of that usage, etc. We want to look at ages, so we need to think about how we want to group patients. We obviously want pediatric patients separated out for reasons of having obviously different concerns regarding treatment. And so this is just one idea of what a dashboard could look like. And then here's another one. So not as colorful, white background, has some different metrics. So this one is an example related to, well, it's an emergency department example for COVID-19. So it has the results by day, which you could use anything by day to see the trends over time and have the divided bar graphs. So all different ways to show the data. Here's another example where you can have a line listing as well. And so some of these things, like a line listing, would not be something that you would want top level leadership to have. They're not in the weeds to that degree. They don't require that information, and it's personal health information. So we don't want that going beyond where it needs to be used for clinical decision making or for surveillance. So lots of decisions to make. We would definitely be interested to know what you would include in a dashboard for the situation, for the use cases that we've been talking about, and help inform our development. So that's the end of our presentation. You can find us at ASPRDT at hhs.gov. That goes to all of our team members. We will be using that for our duty officers during an active response. So we invite you to reach out to us at any time to communicate with us. So I'm going to stop sharing. And I think I'm passing it off to Dr. Boyle now.
That was incredible, and there are at least 8 questions in the Q&A and growing. So maybe we can just start from the top, because I think we'll try to get through as much as we can. So Thomas Barnett asks, what kinds of plans, policies, and procedures have been put in place around the cybersecurity of your remote devices?
Cybersecurity is Amy and Chris. Amy, do you want to talk about it from the device perspective?
Sure. There are standards that are in place through to address cybersecurity, and the devices that we are looking at, a lot of them are elevated to the DoD standards at this point. But so we are currently looking at evaluating these, as I think Chris can speak to. The overall program goes through an evaluation through FedRAMP and other mechanisms. So we are keeping in mind some of the cybersecurity issues that are more present through working with the DoD in one of their current scenarios. That is the NDMS pilot program, where they're looking at an influx of military casualties coming in through DoD, transferring to facilities through NDMS, and being in the NDMS hospitals, providing the definitive medical management of these patients once the DoD system is overwhelmed. So through this, we've been looking at different types of attacks that occur to the IT systems and integrating that into our planning, so that we don't have the definitive recommendations at this time, but we are looking at all the different mechanisms that we can utilize to protect our system as best possible.
Yeah, so in brief, just so we can hit
Sorry.
the questions, it is something that we're aware of and that we're actively looking at. We have to do that. We want to do that, and we will be doing it. So thank you for the question.
Are there pediatric specialists included? Dr. Morrison wants to know.
Yep, they're part of our lineup. So not just, pediatricians, but emergency pediatricians and pediatric orthopedists, all of the different specialties that would assist with pediatric patients.
And then can you describe the mental health components in more detail?
This one I'm going to pass to Chris, who has, and Amy, actually both of you who have been working closely with our behavioral health group, which we have internally at ASPR. So Amy, do you just want to provide a few words around what you have been discussing with them?
Sure. So behavioral health can be anything from assisting the team to provide first aid and triage in the field as they go door to door. It may be the management, like medical management. If we have social workers in the field through public health service, they can be assisted by a reach back psychiatrist if prescriptions are involved or medical management is involved, as well as setting up kiosks for individual counseling, especially in environments like including remote facilities or shelters. It's just a couple of use cases.
Thank you. This is one of our high priority use cases. So we're working very closely with our behavioral health team.
There's a question about e-prescribing. So experience in many DMAT assignments and the EMR, or the individual is experienced. And they want to know, how will e-prescribing generally work, especially when finding an open functioning pharmacy is always a challenge in these areas. So how will these remote providers know where to send prescriptions?
What?
I can take this. So the background disaster telemedicine, the goal is to find the systems, the pharmacy systems that actually are working, so that we've narrowed down the ability for people to, they'll e-prescribe according to what's actually available in that area. So they can actually identify where they want to go. If they have a relative that's somewhere that they can get to, they can get the medication, versus what is still open and functioning in the surrounding area.
Chris?
And if I can add, yeah, thank you. And in addition to that, we have the capability of integrating EPAP, the pharmacies that are associated with that as well, which is a big deal for us. And we're building in a redundancy for the ability to do paper to print out through a secure manner in the event that electronic prescription is not functioning.
Thanks, Chris. I also want to just back up, because it also includes the how do we know someone has prescribing privileges from the telemedicine side, and that's a complicated process of getting people onboarded onto the system so that they can use e-prescribing. And I will not go into detail because we have not finalized that, but it's complicated.
So there's, I'm going to jump in line because I think it's a related question, but there's a question about licensure, and I think you mentioned that the providers will be federalized. Is that, how will this work, for your workforce? Because it's a legitimate concern with cross-jurisdictional response.
Yep, we know that that's a huge concern. Top of the list, our contractors will be federalized, so that means that they will be covered by the tort, the tort protections. And then if they're NDMS, then they're already federal, obviously public health service. So that's the idea at this point, is to leverage the ability that we have to not be bogged down by requirements that would otherwise be applicable.
And do you anticipate then that your bench will be sort of deep enough that you won't need to add additional individuals for a large enough event?
Yeah, I mean, you have to be,
yeah, you have to be realistic, but just curious. I think people are asking some questions about, how would do you have a mechanism in place that would allow you to do that, understanding that wouldn't be your first go-to?
To go outside, we don't have a mechanism at this point, and it's something to think about down the line. What's really important right now, and not to get into the boring financial details, but we got one bolus of money in the FY23 omnibus budget, and we have not been funded outside of that. So in order to both impress upon Congress and frankly HHS leadership that this is a necessary service, we need to demonstrate that we have that value. And that is by, leveraging some of this lower hanging fruit to demonstrate that. But it's obviously something that we need to consider as we grow the program.
There's a question about whether the program will be used in conjunction with a DMAT deployment or whether clinicians working in emergency response at affected hospitals could access the services as well. I guess that's a related question.
Oh, Chris.
Yeah, so one thing that we're working on right now is pre-script admission assignments. And part of that is multifold, but it's to every time behavioral health goes out the door, every time that DMATs go out the door, that this capability goes out with them. And also the capability of deploying it separately of that. But yes, our intent is to have the capability in their back pocket, both behavioral health and for DMATs every time.
And Chris, can I add, because I know that you always say this, because of the modular nature of the system, people will be able to, there are things that are not clinical per se. So it could be the translation and interpretation services that we could allow people to use without going into the digital platform for delivering telemedicine more broadly.
There's a question about the use case scenario that you outlined. It was mentioned that the EMT or the remote nurse could connect back to the ER physician at the base of operation. Is that something that would require additional staffing for the DMAT team? They're just wondering about if you can talk a little bit more about how the staffing will work as a whole.
Amy?
Sure. In this specific scenario, the idea is that we are not making decisions in a bubble, that it involves the team that in the base of operations, as well as the EMT who's working on the field to make sure that to collaborate on the disposition of that patient to the base of operations versus the hospital, what resources should and could be, or could and should be utilized, and in what way. So it's just trying to elaborate on how it can support this team decision making through that platform by bringing in expertise, resources into that scenario as well. So we don't see anything. I haven't in the use case scenarios seen a requirement for increasing the staff of DMAT. The idea is just to support the DMAT team as much as possible without having to pull in extra resources from other sites to keep them within the NDMS and ASPR.
And thanks, Amy. And I also wanted to add that, there are obviously, we do have concerns about it, kind of like Amy alluded to increasing burden for anybody who's out in the field doing what they're supposed to be doing and that they always do. The point here is to extend reach, not to limit people's ability to perform their duties on site. So we know that there's logistical concerns for, how do you move equipment? Who's in charge of moving the equipment? Who's accountable for whether the equipment gets lost or broken? And these are all the things that we need to figure out, because it is a high priority not to burden any of our folks out in the field, because that will not be a great way to show our value.
There's a question about whether you could provide some examples of data sets whose API you'll be pulling in.
Chris,
That's a question for Chris.
Talk about HIE and Amy.
Sorry about that. I was trying to multitask. We have a lot going on today. I'm sorry. Can the question on HIE again, please?
It was a question about some examples of data sets whose API you'll be pulling in.
Examples of data sets?
Yeah.
You
I'm
mean
not
what
sure.
what type
Shereen,
what
I don't
type
know.
of
Yeah.
what type of data that we're going to be extracting from
Shereen, I
the
don't know if you
HIEs?
can Damien, can individuals come off mute so they can clarify their question?
Yes, I believe you're looking for the question from Dr. Adabaki.
Yes.
Give me 1 second here to unmute her.
Thank you. By the way, there's many laudatory comments in the chat, so I'm hopeful that we'll be able to print and share these with you. People are very excited. Dr. Adabaki, you there? Do you want to come off mute?
Dr. Adabaki, attempt to unmute your microphone.
Oh, got it. Okay. I thank you so much, Damien and Dr. Boyle. My question was, what are the sources that you're looking at, not the specific data points? Are you looking at, FEMA data? Where are the sources of some of the data that you're going to pull in utilizing API?
Sure. It's coming from, I say two sources, but two buckets, I can call them. One is, clearinghouses. There's two. I want to call the names, two of the largest ones in the United States that are health information exchanges. They're coming from them. That we have, our contractor has agreements with them, as well as from 100 hospital systems across the United States, some of the largest ones that they're choosing based off of their location to trying to use, and they use what they call background algorithms to try to pull from all these different sources to make a complete record. And that those records obviously would consist of, depending on what they are, of that data. And so we intend to pull but not push any of our data into any of them. So it's strictly to do a patient lookup and to self-populate our records, and that's it. We're not going to exchange data. It's more of just the pull, and hopefully that answered your question.
Yes, thank you.
And I would say it's, unidirectional at this point. As the program develops, we will figure out what the needs are and shape the program to meet them to the degree that we can.
I'm going to jump in line to a question about threshold for activation. So could you clarify what it sounds like this would be? Your activation would be primarily in federally declared emergencies. Are there other situations where this would be available for use?
Yes, at this time, this will be available for federal deployments. Anything that's a ESF8 deployment, deployments that ASPR is involved in, and then we hope to incorporate the other federal providers shortly. That requires some work, but we do not have a mechanism for supporting other entities at this point, but stay tuned.
And then there's a few more questions. There's some suggestion about I think I know the answer to this, because you said you are planning your initial operations for the fall, so presumably you're not operational yet, but clearly folks are thinking that the use case in North Carolina currently is a great example of where your services could be really useful.
Yep. Yes, we are reminded of that every time something has happened since we've even been a twinkle in anybody's eye.
Yeah.
We are trying to get up and running as soon as we can.
I'm going to put one last question, and then I know we're at the top of the hour, but can you speak to any integration plans of the EMR system with other federal EMRs, such as the DoD or the VA?
I'll just say that, this, and Amy is really the one who's knee deep in all this right now. But the ongoing issue is the civ-mil divide. So I think DoD and VA just started working on integrating their EMRs. So I think getting over that divide is a significant hurdle that we are trying to solve through some other projects. And again, that's a get back. We'll stand by. We're going to see where we can go in the current, in the coming months and years.
And I'm going to throw in, as moderator's privilege, what can we do to send the message that this is a program that really needs continued investment as stakeholders?
I think just knowing that we are not funded and have not been funded, we're now in FY25. So we received, $6.5 million in that FY23 omnibus, is being able to state the case for the need in your geographic area, or if you're in an NDMS provider, you would have that perspective as well, and be able to articulate what a service like this would, how that would improve your response. And, we can't talk to our congressional delegates, but other people can. So, whatever levers you have, go for it.
All right, it is the top of the hour. I want to be respectful of everybody's time. Thank you so much for really your incredible work. It's amazing to see how far this has come, and we are all extremely excited. I'm sure that if there are questions, that you'd be willing to field them. And I think, Damien, if you can put up that email information, email contact, I'd encourage participants to reach out, engage, stay active. I know that this team has been incredibly responsive and really thinking very hard about how to solve really hard problems. So
thanks, Tanaz. Can I also add a thing, which is just to apologize that we have not been in front of you sooner, but we would not have been able to provide you the detailed information that we have now as the program has matured. So thank you for your patience. I hope that it's been helpful.
We're looking forward to hearing more. All right. Thank you.
Bye, everyone. Thank you.